Our speaker for second talk today is the Dean of Postgraduate Sciences and Professor of Medicine at Faisalabad Medical College, which is Punjab Medical College, Professor Amir Shaukat. He is also very actively managing the COVID patients these days, and he's in charge of the COVID management. He's also the Deputy Dean of Punjab Medical College of Faisalabad. It's my honor to introduce Professor Amir Shaukat, who will be talking to you about resistant hypertension. Sure. Professor Amir is also the chapter head of Faisalabad chapter of Pakistan Society of Internal Medicine.
Right. Bismillahirrahmanirrahim. Thank you very much, Dr. Somia, for your nice introduction. I'm extremely honored to have been given this opportunity to be a part of this webinar, and I always feel very delighted to be part of any educational activity in general, and particularly speaking on the forum of PSIM makes me absolutely delighted today. Dr. Rizur Rahman is my mentor. I'm very fan of his presentations, and the way he's gone through his presentation was really, he beautifully captured the various aspects of hypertension. The target given to me today was to discuss the various issues behind resistant hypertension, how to define it, how to go about the various pathophysiological mechanisms behind resistant hypertension, and plus to make you understand how this aspect of hypertension needs to be taken up and how this aspect of hypertension is different from the various other problems behind hypertension. So by definition, resistant hypertension is defined as a blood pressure that remains above goal in spite of concurrent use of 3 antihypertensive agents of different classes. One of these 3 agents, at least one of them, has to be a diuretic drug. Although patients with resistant hypertension may have elevations both in systolic and diastolic blood pressures, but isolated systolic hypertension is more common. The systematic approach to the diagnosis of this part of hypertension begins with that the blood pressure remains above goal in spite of, as you can see, compliance with the maximum dose of antihypertensive drugs. Of more than 3 antihypertensive medications the patient should also be using, and from different classes, and ideally it should include a diuretic as well. So this is like the various issues that are behind resistant hypertension, which means the patient should be compliant on a lifestyle, but he is not achieving his blood pressure. He's already using 3 drugs. One of them is a diuretic, and it is being used at optimal dosage. The blood pressure still is not controlled, is when we would label him to be suffering from resistant hypertension. So this resistant hypertension is to be defined and differentiated from uncontrolled hypertension. A majority of my students and postgraduate residents keep on coming to me and asking this question, that is this an uncontrolled hypertension or is this a treatment-resistant hypertension? So by definition, uncontrolled hypertension includes patients who lack blood pressure control for any reason because of inadequate treatment regimens, because of poor adherence, because of undetected secondary hypertension, or because of true treatment resistance. On the other hand, treatment-resistant hypertension, as we say, is again a repetition of the previous definition, which means that the blood pressure. Professor Aziz Saab?
Professor Aziz, आप अपना अगर mic kindly mute कर लें. So.
Right. So uncontrolled hypertension needs to be defined from treatment-resistant hypertension. And uncontrolled hypertension includes patients who lack blood pressure control for any reason, including inadequate treatment regimen, poor adherence, undetected secondary hypertension, and true treatment resistance. On the other hand, treatment resistance is basically the same definition as we've been going on in the previous slides that the blood pressure remains above goal even with maximum tolerated doses of more than 3 antihypertensive drugs, and one of them has to be a diuretic. Now, this resistant hypertension is also to be differentiated from refractory hypertension. Now, some patients with resistant hypertension cannot be controlled even with maximum medical therapy, which means 4 or more drugs with complementary mechanisms given at a maximum tolerated dose under the care of a specialist. These ones are the ones who fall into the group of what is known as refractory hypertension. So now we've got 3 things to work out with. Number 1 is uncontrolled hypertension. This is different from resistant hypertension. And then is this aspect of what is known as refractory hypertension. You know that blood pressure plays a havoc with our body. It affects more or less every part of our body, and end organ damage because of hypertension, which is one thing that we would be learning about and would be discussing very often in the upcoming slides. Is it can cause stroke, visual losses, heart failure, kidney disease, sexual dysfunction, etc. The target blood pressure is very nicely been told to us by Professor Azizur Rahman, but generally talking, is the ones who are non-diabetic and who don't have kidney damage should be a blood pressure of systolic 140 and a diastolic of 90. The ones who have kidney damage and are suffering from diabetes, the target blood pressure should be 130 over 80 or less than that. The various terminologies that we will be discussing as we go on by my slides of resistant hypertension include an apparent resistant hypertension, a pseudo-resistant hypertension, and true resistant hypertension. Apparent resistant hypertension are basically those patients who have uncontrolled clinic blood pressure that is greater than or equal to 140 over 90 millimeters of mercury, despite being prescribed 3 or more antihypertensive medications or require prescription of 4 or more drugs to control their blood pressure. So this is what is जिसको हम सोचेंगे कि probably इसको resistant hypertension है. So what is known as a apparent resistant hypertension needs to be differentiated from this term, which is known as pseudo-resistant hypertension. Pseudo-resistant hypertension refers to poorly controlled blood pressure that appears resistant to treatment but is actually attributed to other factors. And the common factors to which the pseudo-resistance is attributed to would be a white coat hypertension, which means that a blood pressure in which there is no target end organ damage, and you don't have an end organ damage, which is minimal in white coat hypertension, or it is because of uncompressible arteries because of old age, which is known as oscillar pseudohypertension, or there's a problem in the checking of blood pressure and the doctor or the physician is not sure how to do it. So this is a measurement issue because of either small cough or other issues. And blood pressure is recorded without 5 to 10 minutes of rest, and there is non-compliance with drug treatment, and patient is not sticking to a lifestyle modification, which means I'll go back to the earlier slides, which would make you understand that apparently when a patient would come to you and say, and you would believe that this probably is a resistant hypertension going on, before labeling him as a patient of true resistant hypertension, kindly rule out this issue of a pseudo-resistant hypertension, because the various factors or the various reasons because or behind pseudo-resistant hypertension are the ones given here, and these are very important ones which should be kept in mind before you take him up and treat him as a patient of resistant hypertension. True resistant, again, I want you to memorize this definition now, that patients with true resistant hypertension are again the ones who have uncontrolled clinic blood pressure despite being compliant with an antihypertensive regimen that includes 3 or more drugs and should have a diuretic at an optimal dose. Now, blood pressure measurement, I thought I would spend 1 to 2 minutes on the technique of checking blood pressure, because when we go down our clinical practices and become very busy, we basically start forgetting the true standards and the true trainings and the true teachings behind how to check blood pressure normally. And that blood pressure has to be checked in sitting position and standing position, should be checked in both arms. The 2 readings should be done 5 minutes apart. Rarely, sometimes you should be required, or the lower limb blood pressure should also be taken. After resting, preferably on the same day of the morning and more so in the mornings. The corticoff phase 5 which is an absolute disappearance of the diastolic sound, should be kept in mind. And the standard cuff size, the one over here, should be applied, and the large cuff size of this size should be applied, and the calibration of the instrument should be done from time to time. The cuff should circle at least 80% of the arm, and there should be very less thin clothing underneath. There should be quiet environment, relaxed doctor and patient, no smoking, alcohol, and caffeine for the patient, auscultatory cap, and keep in mind phase 4, etc. So the blood pressure checking should be a part of your practice, in the sense that you should be very clear how to go about the various issues and the various techniques of checking blood pressure should be very clear about it. What are the causes of non-compliance of drugs? Now, hypertension in most patients, reason why people don't pay attention to blood pressure is unfortunately because it's an asymptomatic disease. हमें मालूम है कि sugar blood pressure की कोई अलामतें नहीं होती. That is why we don't know that if we are suffering from hypertension or not. And the better way or the best way of going about it is checking it at regular intervals to find out if you are hypertensive or not. Obviously, in the initial stage, unfortunately, despite the various hypertensive societies and the guidelines and the webinars and the lectures we've been delivering over time, majority of patients of hypertension are still being missed in our country, which is a very, very unfortunate part of it. Then people are very concerned about the side effects of these drugs. They are concerned about the cost, combinations, then the complexity of the regimens, multiple drugs, timings of the drugs, multiple medications for controlling comorbidities, lack of understanding of the gravity of the disease, the end organ damage issues, false belief that hypertension got cured, social, economic, personal factors. These are the various factors behind non-compliance and why people still don't stick to a drug regimen. I believe over the years we've been able to give this message that this is one of those disease that needs drugs for the rest of your life. And when you say this thing that the patient would be required to be on a certain medication and he would need to take it for the rest of his life, patient would never comply to a drug. We belong to a society. So this is one aspect of this disease which we won't be able to cover unless we come into a sort of a coherent environment with the patient and we start educating him and telling him on regular intervals and then keep on encouraging him so that not only he achieves his target blood pressure but complies to medicine at regular intervals. Now, this issue of non-compliance is to be addressed by these two phenomena given over here. That is, you should be directly responsible and take the patient into your hand and admit, administer, and regular at the same time, and monitor at the same time. The clinical parameters which needs to be checked when a patient is being labeled as resistant hypertension includes the age, the high baseline blood pressure, obesity, overweight, excessive dietary salt intake, alcoholism, chronic kidney disease, diabetes type 2, left ventricular hypertrophy, black race, female gender. These are the ones which are, I would say, the issues in which resistant hypertension is more commonly seen as compared to the normal population. So these are the various genes that have been implicated as a pathognomic phenomena or behind the pathophysiology of resistant hypertension. The three ones given over here are the ones that research have proven to be probably the three factors or the genetic predisposition to having resistant hypertension. Now, who are at risk? This is again a very commonly asked question. The ones who have resistant hypertension include the patient belonging to an older age group, female sex somehow or the other are more prone to have resistant hypertension, obesity, diabetes, chronic kidney disease, black race, patients with excessive dietary salt ingestion, left ventricular hypertrophy are the ones in which resistant hypertension is more commonly seen as compared to the normal population. Now, the factors behind resistant hypertension could be divided into two parts, a patient-related issue and the physician-related issues. The patient-related issues include when the patient is taking too much sodium, is not adherent to a treatment plan, he is taking drugs that have got some issues behind or has some contraindications we should not be doing, and then there's a lack of a lifestyle. The physician-related issues include a subclinical volume overload, inadequate use of diuretics, progressive renal insufficiency, and unsuspected secondary causes, which means that blood pressure by no means a patient of resistant hypertension should not be taken lightly, in the sense that whenever he walks into your clinic, you should always be
Only I can't see Professor Amir Shaukat, or is he missing? Can somebody confirm?
His presentation is paused. There's some technical issue, I think, at his end, because everybody else is connected.
Yeah. I think let's wait till he reconnects. Let's wait for 1 to 2 minutes. Meanwhile, we can take the opinion of our panelists.
He is back.
And if there
Amir
are
is
any
back. Amir
questions
Shaukat
from
is
the
back.
audience. जी जी सर आप माइक प्लीज अनम्यूट कर लें. सर आप
Right, I'm back on screen. Sorry, it was the connection issue. So, diabetes mellitus, chronic kidney disease, obstructive sleep apnea, and left ventricular hypertrophy.
Amir,
So
you
these
need
are
to
the
share
four-
your screen again.
Right. Sorry, just doing it. Just give me a minute. Can you see it now?
Yes, sir.
Is it okay now? Are you hearing me?
Yes, it is
Yes, sir.
okay.
You're
Up and running.
it's visible now. Yes.
Right. So as I was saying, it is like type 2 diabetes, chronic kidney disease, left ventricular hypertrophy, and obstructive sleep apnea. So problems behind resistant hypertension is like, as I mentioned earlier, it's a problem of controlling the systolic and the diastolic ones. But somehow or the other,
Soumya, you are muted. You are trying to talk, so you are muted.
Sir, I was trying to convey to Professor Amir that he needs to share his screen again and unmute himself. I think there's a connection problem at his end.
are you hearing me now? Is it okay now?
Yes.
Yes, sir, we can hear you. You need to share your screen as well.
So we are now using another net. So I think this would sort of no. Is it okay now?
Yes, sir, it's fine.
Fine, right. So as I was saying, that choking in general about hypertension as a bigger problem. 30% of them, they turn out to be patients of resistant hypertension, and out of 5% of those resistant ones, when they are investigated, they turn out to be suffering from secondary hypertension. The common causes of secondary hypertension are the ones here. This is primary hyperaldosteronism, pheochromocytoma, Cushing syndrome, and renal disorders. The resistant hypertension, to summarize, is a low problem in general population. In specialized clinics, it is close to 15%, and in clinical trials, it is close to 30%. So what to talk about now, this is, if we were to summarize, if we were to sort of reorganize ourselves to think what is the various percentage of patients of the various aspects and the various types of hypertension, then the essential hypertensives are close to 93-95%. Secondary hypertensives are close to 5 to 7%. And we've discussed the various causes behind the secondary hypertensive parts. The mechanisms for secondary hypertension include increased vascular tone, sodium and water retention, abnormal sympathetic nervous system activation, abnormal renin-angiotensin-serine axis activation, and endothelial nitrous oxide mismatch. So which of all these patients are the one who fall into the treatment-resistant hypertensive ones? Again, the treatment-resistant hypertension is a diagnosis of exclusion requiring a systematic approach to evaluation and management. And now is the part in which I would try to tell you how to sort of address when you come across a patient of resistant hypertension. The 4 parts to me, how you would deal about it is confirm the accuracy of blood pressure measurement, optimize pharmacotherapy, and educate and sort of tell your patients again and again to adhere to a drug plan, address lifestyle barriers to control blood pressure, and then consider referral to a specialist. To me, out of all these 4 things, I still believe that confirm accuracy of blood pressure measurement is the most important. And again, a repetition that blood pressure should be measured in both arms, weight and waist circumference, body mass index calculation. We should all be knowing how to do about it. Peripheral pulses, carotid bruise, etc. Thyroid examination, cardiovascular examination, fundus examination, abdominal examination, fundus examination for end organ damage issues and retinopathies should be done in every patient in which you suspect him to be suffering from resistant hypertension. So tips for obtaining an accurate blood pressure reading is to be done in a silent environment for 5 minutes. And we've discussed this previously, and kindly make it a point that the cuff should be properly placed. It should encircle at least 80% of the patient's arm circumference, and other factors that can affect blood pressure reading, including recent caffeine, nicotine, and alcohol consumption, full bladder, or if you are talking with the patient and there's a background noise, we should try to eliminate and reduce this as much as we can. So this is, automated blood pressure apparatuses are now very fashionable. People use it at homes. I don't want to discourage it, and now the general guy, but again, this automated blood pressure device, whenever it needs to be used for self-monitoring, the patient should be very clear about how to do it. And the same phenomena given over here should be applicable to the one patient who wants to do it at home as well. The automated blood pressure measurement has several advantages. It minimizes potential for error use if the patient is using it correctly. It enables efficient collection of multiple blood pressure readings, obviously, and reduces patient anxiety and the effect of white coat hypertension, and aids in detection of white coat effect. The average of 5 blood pressure readings taken 1 minute apart while the patient is alone in a room, has been shown to approach average walking blood pressure. And home blood pressure measurement is obviously a useful tool because of these problems, and the various consideration should be that the patient should be trained in proper blood pressure measurement techniques, should utilize validated monitors to ensure accuracy. Patient should bring new devices to clinic to confirm accuracy as well. So if you use it and you educate your patient properly and give him time and he understands how to use this device, then this automated blood pressure measurement obviously is a good tool to rule white hypertension out and for the self-monitoring and control of blood pressure. But we again don't want to be in a society which creates panics, because unfortunately, if the device is not being used, probably this is what's going to happen. You are going to get a lot of phone calls. I get them a lot. When patients keep on calling me again and again and telling me that the blood pressure is not being controlled and the drugs that you've prescribed, unfortunately, are not working. But it is more of a problem of applying and how to check the blood pressure rather than a problem of the drugs that he's using. If the patient has got, or you want to label him as a patient of secondary hypertension, then he would be required to go for the high profile tests, including the angiographies and the digital subtraction angiographies, MRI, CTs, etc. But this is for the secondary hypertension. The lifestyle principles of hypertension, basically they remain the same. They include salt restriction, encourage your patient to lose weight, physical activity, stop alcoholism, smoking cessation, and good glycemic and lipid control. This is what we don't do. Our take-home message today should be to restrict salt as much as you can do and come to a lifestyle modification. We don't want our bellies to blow up like this, especially when we are passing through the time of COVID pandemic. And we should be enabled to optimize pharmacotherapy and encourage patients to adhere to a drug plan. The choice of drugs should be individualized, and this may depend upon the consideration of prior benefit, of histories of adverse effects, financial limitations, and the presence of concomitant disorders such as kidney disease, diabetes, etc. So a good knowledge of the drug, a good knowledge of its side effects, and then choosing the drug that potentially is renoprotective, that would not enhance or increase the amount of kidney damage that has already been done, is very important. My education to my students has always been blood pressure is, although a problem of bringing down numbers, that it would be very adequate that if a patient has got a blood pressure of 180 by 100 and you bring it down in 2 days from 180 to 100 to 130 over 80, you've done a wonderful job. But to me, it would be more important about the choice of drugs that the doctor is choosing for controlling his hypertension, because unless you are clear about the pathophysiology of the various agents that are used to control blood pressure, it would not be a rational thing as on the point of the physician to control it if he doesn't know what he's actually trying to do. So for that, the guidelines that were educated toward very beautifully by Professor Yusur Rahman obviously are very helpful, and these guidelines are meant for you to choose and optimize for yourself which drug and which agent to administer at which part and which stage of the drug of the disease. But again, keeping in mind the end organ damages sites of blood pressure and choosing a drug accordingly would be more advisable. The drug treatment of resistant hypertension, if a correct cause is found, then treat that cause. Aggressive drug therapy, optimizing the drug current treatment, effective diuresis, then MRA, antagonists, spironolactone, etc., hydralazine, minoxidil, beta blocker, diuretic, these all been told by Professor Yusur Rahman. So the practical points of resistant hypertension is kindly consider plasma renin measurement, adding dexamethasone to the regimen, and obviously addition of a diuretic. These are the various future drugs which are coming up. Some of them are available here, some of them are not, but we need to keep in mind, because for patients of resistant and then of patients of refractory hypertension, these would be the agents which obviously would be helpful, including the direct renin inhibitors, the neutral endopeptidase inhibitors, the aldosterone antagonists, aldosterone synthetase inhibitors, clonidine extended release tablets, endothelin antagonists, and the novel combination algorithms. So the non-pharmacological approaches coming up, but again, this is a new thing to us. The following procedures are invasive, obviously, and are irreversible, but they include implantable pulse generators, a prevascular carotid sinus leading to the which needs to be surgically implanted, renal denervation, particularly in those with the renal origin of the disease, is showing promising results, and the neurovascular decompensation, but this is a temporary procedure. So better safe than sorry, and you can enjoy diabetes, high cholesterol and hypertension, or you can suffer from a good health. So every doctor needs to give this education and this message to his patient so as to stick to a diet plan, come to lifestyle modification, and use the correct drugs. Stop salt. The take-home message should be today for today. It's about time that we now use this message and spread it all over and start restricting the amount of salt that we take every day. So thank you very much for your patient listening. I've tried to be, stick to the target given to me of talking about the various aspects of resistant hypertension. I hope that I've been able to address the major issues behind it, and would be more than welcome to take comments, questions, and address the various issues of hypertension. Thank you.